further ado, I'm going to hand it over to Lynn. Lynn, thank you so much for joining us this morning. So Lynn Elsey is a consultant respiratory pharmacist at Manchester University NHS Foundation Trust with a clinical interest in severe asthma. Lynn is currently undertaking a PhD exploring the impact of a digital inhaler monitoring on adherence in asthma at the University of Manchester. She is also a member of the British Thoracic Society Respiratory Pharmacist Specialist Advisory Group. She represents the BTS on the Task Force for Lung Health Treatment Working Group and is the pharmacist committee member on the NICE asthma guidelines. She has an interest in sustainability and is a co-lead for the Centre for Sustainable Health Respiratory Sustainability Network. Over to you, Lynn.
Thanks very much for the introduction. I'll just share my slides. It worked before, so hopefully it will work now. Hey, there we are. Can everyone see that okay? So thank you very much for asking me to come along today. As we said, so I'm a consultant respiratory pharmacist. I'm based mainly at Withenshaw Hospital in the North West Lung Centre, and I'm doing my PhD part-time over 6 years at the University of Manchester, as I said, focusing on digital interventions to improve adherence in asthma. So today I'm firstly going to start with just a bit of an insight into how I've developed into a pharmacist, clinical academic researcher in the pharmacy research pathway. Look at the scope of non-adherence in asthma and why this is an area that I chose to research. And the areas that I'm looking at, such as patient behaviour and attitude to inhalers, and the digital interventions that are available to hopefully improve adherence. And then just have a look at the study that I'm undertaking and the sort of evidence, opportunities and challenges of implementing this sort of technology in the clinical pathway. So just to begin, I tried to do a bit of a timeline of how I got to doing my PhD and the pharmacist research pathway. So if you look at it, it's a nice straight line, successful awards, getting grants, getting ethics, and now undertaking my study. But really, if you look at it in a realistic way, this pathway looks very different. I started my Master of Pharmacy degree in 2000. I'm now undertaking my PhD. I started in 2023. Along the way, there's been lots of successes, and I've been lucky in the opportunities I've had. But there's also been failures and unsuccessful grant applications, and I think it's really important to give that sort of realistic overview that it doesn't always run smoothly, and that's okay. And you will eventually get there if it's something that you want to do. Really, my passion for research, I'd always considered doing a PhD, but once I did my Master of Pharmacy, you then choose the area of pharmacy you want to work in. I chose to work in hospital pharmacy, which is a real clinical focus, and most pharmacists will undertake a postgraduate diploma in clinical pharmacy, which you can then take forward to a Master of Science in clinical pharmacy, but often there's not the opportunities or the funding available. I was lucky to get funding offered from the university where I did my postgraduate diploma to do my MSc, and I was lucky enough that I was working within paediatrics and cystic fibrosis, and it was an area that we knew we needed to do research into how we provided antibiotics, and mainly to look at the impact it was having on the trust, the hospital admissions and funding. So I was able to sort of convince people that this was an area that I could research for patient benefit, and I got the funding to undertake my MSc, but I had to do it within my own time. And I think this is one of the barriers that we often come across is time within your work to do this research. We were able to successfully show that we could make a huge impact on patient treatment time, 2 hours per day to give these IV antibiotics at home. And there was reduced admissions to hospital, and we were able to fund a home care IV service. And I think this is the reason why we should be doing this research, is for that patient benefit and benefit to the service as well. I did that whilst I was pregnant. I took time away then, and I think this is often the story within a pathway of research, that you don't always move forward to the next step straight away. But I moved into a role within severe asthma where the team was very research active. We have a consultant speech and language therapist who's undertaking a PhD and a consultant nurse who was undertaking a PhD. And it really drove me forward to look at how I could look at the consultant pharmacist pathway. We were working in an area where we had brand new biologic treatments, high cost treatments for asthma. And we were trying to understand what the real world evidence was for these. And we were presenting this work at international and national conferences and publishing within the European Respiratory Journal as well to try and shape better practice through our research. And I realised that I could use this to take it forward and hopefully gain my PhD. I also, in this time, really built up my role within national platforms. We said I worked for the British Thoracic Society. I've worked with Health Innovation Manchester and how we could roll out the work we were doing at Wythenshawe further across primary and secondary care in terms of improving patients' use of asthma medication. And then I was successful in becoming the pharmacist advisor for the national NICE asthma guidelines. And this all gave me a voice really on a national platform, but helped me understand more about where there was gaps in the evidence and where we needed to do further research. And adherence came up time and time again. The consultant pharmacist pathway, as with nurses and AHPs, has these 5 pillars, one of the main ones being research, where you need to demonstrate that you evaluate the evidence base and you undertake research to inform service innovation. And really, to be able to become a consultant pharmacist, you have to do a portfolio for the Royal Pharmaceutical Society and show evidence of this. So I really wanted to not just do it in my day-to-day practice, but take it forward to develop as a clinical academic. And that was where I began really looking for funding for my PhD. And I was successful in my consultant pharmacist credentialing 2 years ago. We talked about the bridging schemes, they were mentioned at the start there, and I was successful in getting an NIHR bridging scheme. Gave me £10,000 of funding, which gave me a day a week of my time where I could dedicate and focus on writing a fellowship application. It's a long process, but also to gain more skills in research, and they offer training opportunities and training days to gain skills on writing fellowship applications, writing publications, ethics applications, and areas like this. And I did go on and apply for grants. And as I said, I wasn't always successful. I applied for a pharmacy research grant and for the NHR Clinical Doctor Fellowship. But every time that I wasn't successful, I gained from it. I gained the understanding that I needed more time, that I needed more training, that I needed to restructure my plans. So although it wasn't a success, it actually led to my success, I think. And I was able in 2023 to get an MFT NMAP fellowship, which thankfully, although pharmacists aren't AHPs, they actually opened up to pharmacists as well. And this gave me funding to enrol on the University Pharmacy Practice PhD programme. It didn't cover my project or staff costs, but it was really the start of moving forward with gaining my PhD. And I tried NIHR research for patient benefit grants and wasn't successful, but then I approached, so it's about finding the right source of funding. Within the Northwest Lung Centre, we have a charity which offers funding for research. And I approached them as they knew about my work. It was people I work with clinically, and it was an area they were also interested in terms of improving people's use of their medication in asthma and other chronic disease. So I asked them, and I put in an application to fund my project for digital inhalers and looking at how they impacted on asthma care, and that I was successful, and they have given me a grant to fund my project. And when I was thinking about this pathway, I found this report. It's from NHS England, and it's a report of a survey of pharmacy professionals that are involved in research, and they looked at enablers and barriers, and they really matched up depending on which area people were working in. There's still a lot of national variation and people being able to gain grants and gain time and gain support from their departments. Enablers were protected time, mentorship, strategy and funding really. And they were also seen as barriers. quite often I think we don't know where these opportunities are, and I think that's where Catalys is really useful. I now also work as a capacity building lead with the Biomedical Research Centre for Manchester, linking respiratory and pharmacy roles, and giving pharmacy a voice within that and access to the grants that are available. And I think the more and more that we can share this information, the more that people will realise that it is a pathway that you can take, and there is more support. I think within MFT, we now have a pharmacy research group where younger pharmacists can come along, or people can come along with their ideas, and we can help and support them and try and find them funding as well. So really, this has led me now to be undertaking my PhD, and it is focused on improving adherence in asthma. I've worked within asthma for about 15 years, and day in and day out, I see that people are not well, they're exacerbating, they're ending up in hospital, they're being exposed to oral steroid tablets, which lead to long-term side effects. And often the driver of this is that they're not using their inhaled medication correctly, either intentionally or unintentionally. And we do know that there is a lot of different interventions out there, but digital interventions have shown the potential for success. That's why I wanted to look at whether this was something that could change our practice. Within asthma, since 1885, we've had medication available up until current dates, where we now have these targeted biologic treatments, which can potentially put patients into clinical remission. But the key cornerstone of treatment is inhaled therapies to try and undo the inflammation in the lungs and the bronchospasm that leads to people having asthma attacks. So now that we have these treatments, you would think everything is solved. But unfortunately, within the UK, we still have significant preventable deaths from asthma, around 4 deaths per day, and mortality has actually increased by 26% from 2012 to 2020. And many of these asthma deaths, 2/3 are deemed preventable. And often it's linked with people not having access to treatment, not knowing how to use the inhalers, or not using them correctly. And so this is why I want to look at this, because it's not just a problem within my own hospital, it is a national problem. There's many factors that impact this. We know that 80% of asthma patients use their inhalers incorrectly. Adherence is around 30%, and 1 million asthma patients will rely on what we call their reliever inhalers, or blue inhalers, or suboptimal inhalers, because it's the first inhaler many have been given, and it gives them instant relief, but it doesn't treat the underlying inflammation that causes their asthma. But patients aren't the only people at fault, and a lot of my research is also, I want to focus on the healthcare professional factors, because 9% of healthcare professionals, only 9% can demonstrate how to use an inhaler correctly. And only 43% of healthcare professionals working within respiratory at MFT would check an inhaler technique. And when we surveyed them, only 44% felt confident in how to show a patient how to use an inhaler. So if we can't show them how to use it, how do we expect that patients will be able to use it? And 1/3 of patients within the UK are reviewed face-to-face annually, but 2/3 have a phone call to check that they're okay. And you can't really check if patients are correctly using treatments such as inhalers over a phone call either. So as I said, I worked within developing new national guidelines for asthma. This is the algorithm that we came up with, and we were innovative in the way that we did this, in that we took away salbutamol or short-acting inhalers from the guidance. We reviewed the evidence, and we found that there are new solutions, new combination inhalers, which can greatly reduce the risk of an asthma patient having an asthma exacerbation or ending up in hospital. And so we've completely revised the guidelines, and we're currently, over the last year, trying to implement them nationally. And we hope that this will start to improve outcomes. However, these guidelines, we know, will only make a difference if patients respond to the treatment and use the treatment correctly. And something that came up time and time again when we were developing these guidelines was that suboptimal adherence to treatment which is seen in all chronic diseases, will lead to lack of response and can lead to inappropriate escalation of treatment. So it's a key factor that is highlighted in the guidelines that we need to consider. And adherence within asthma is sometimes more complicated than other chronic diseases. I mean, adherence in itself is that process of initiating a treatment, implementing it, and persisting with it. And there's so many different factors that can influence that. But within asthma, patients' symptoms often wax and wane. So they'll have days where they feel completely fine, completely healthy. And then they'll have days when their asthma is bad. And they may, on the days they're good, not use their treatment. On the days they're bad, maybe use it that day and it doesn't have the effect that it needs to have. It's also more complicated because it's not just simply swallowing a tablet. They have to know how to correctly breathe in at the correct rate for the type of inhalers that they have. So there's many different factors that can influence this already complicated process. And from my clinical practice and my national roles, I know that non-adherence is leading to unnecessary referrals, costly escalation, and it has a high financial burden on the healthcare system within the UK, really in a time where the finances are particularly strained within the NHS. We need to look at opportunities to reduce this wastage. It's an area that has been researched, and sometimes this did kind of make it more difficult to apply for grants was finding the area that we needed to specifically look at, because there's a lot of research that has already been done within adherence and asthma. This is one study from Leicester which showed that if patients used over 80% of their doses of their prescribed inhaler, they would have reduced inflammation, reduced exacerbations. But most importantly, if they were admitted to hospital, there was a reduced risk that they would end up on a ventilator in intensive care. So it's very important that we get them to this level and using their inhaler at the correct rate. So we classify, if someone uses over 75% of the prescribed dose, we classify them as having good adherence. Within clinical practice, we have lots of different measures of inhaler adherence. We can ask the patient themselves. We can use self-reported questionnaires, but we know they have high specificity but low sensitivity. They often won't pick up if a patient does have poor adherence, because often patients will give you the answer they think you want to hear. We use prescription refill, where we will look at their GP records. We have a great system within Greater Manchester, we can do that. But again, that just shows that a prescription was issued for that patient, not that they used it or used it correctly. We do have dose counters on inhalers, which again can sometimes show, but actually more and more we're realising that having an electronic solution that can monitor real-time use of inhalers would give a clearer picture of what patients are doing at home. And all of this is really impacted by so many different factors, as we said, but we often use the COM-B, or capability, opportunity and motivation model to help us truly understand patients' behaviours and how they impact their adherence to medication. So capability, that's psychological or physical ability to use the medication, having the opportunity, simply having someone prescribe it for them, having the money to pay for the treatments, or having family support to enable you to use it. And also the motivation, which, as we've said, in asthma can often wax and wane depending on what their symptoms are like. So many different factors that influence this process. And within my research, we're trying to greater understand the impact that these different behaviours have and influence on adherence. So part of my research, I'm working with Asthma and Lung UK, so our sort of national charity body that supports asthma, who have done a behavioural insight survey, which collected responses from 2,324 patients with asthma across the UK, with a good spread of female versus male patients and age and income, particularly respondents from the white British population. But it found that 69% of patients reported that they were using their inhalers daily, their preventer inhaled steroid, they were using it on a daily basis. But 31% reported that they were not. And we looked and created personas of these patients. Because adherent patients tended to be older. They wanted to take care of their asthma. They monitor the symptoms. They recognise when their asthma is worsening. They'll attend their GP and they know about their inhalers and how to use them correctly. Whereas we have this higher risk group of younger, higher educated patients who are not interested in managing asthma. They don't go to their GP. They search for information online and they don't want to engage in routine or use medication regularly. So if you think about the NICE guidelines that we produced, which talk about using medication regularly, this isn't a solution for this group of patients, and we need to look at more personalised solutions to reduce their risk. We're looking at the results of the survey to try and create a risk matrix and potentially a questionnaire that can help identify these different personas within the clinic so that you can create more personalised solutions to reduce their risk. And one of these potential solutions may be digital inhalers. So what are digital inhaler monitors? So they are small devices that are either built into or attached to the inhaler device. We have ones that will attach onto the top or bottom of the inhaler depending on the inhaler type. And when the patient activates to use the inhaler, it captures this and then sends information by Bluetooth to an app on the patient's phone. It can be attached to their daily preventer inhaler or their reliever inhaler to give insight into their asthma control. And the patient app will give the patient notifications and will give them feedback as well on when they're using it and reminders that it's time to use their treatment. So it can help them build it into their daily routine. And we have a healthcare professional portal which will give us access to the reports on how they're using their treatment as well. So it gives you that real world data on what their adherence is. There has been systematic reviews. There was a Cochrane review in 2022 of different digital interventions in asthma. And these digital inhaler monitors were found to potentially significantly improve adherence with significant improvements in asthma control. This was a small number where the asthma control findings. There was a lot of heterogeneity within the studies. There was a lot of impact from what we call the Hawthorne effect. So in many of the studies, both the control and the intervention groups had monitors on their inhalers, but just with different settings. So the Hawthorne effect is that change in behaviour from knowing you're being monitored. So the outcomes really showed that we need to do further larger studies looking and comparing with just standard care, basically. We began by evaluating these sensors within our severe asthma population. So patients referred to us as uncontrolled asthma, potentially needing high-cost biologic injections. Now, one of the important things is that they have to be uncontrolled despite being adherent to their inhalers. So we use these digital sensors with ourselves in Portsmouth Hospital, monitoring adherence over a 6-month period and looking at the feasibility of implementing this technology into the severe asthma pathway. It gave you a report like this from their app on their phone when they were using their reliever and the preventer inhalers. This patient had good adherence. And we found basically we created a Sankey diagram of where the patient journeys. Many went from some went from non-adherent to adherent, some went from adherent to non-adherent, and some patients weren't using their inhalers at the start and continued not to use it. So it really highlighted to us that this technology may not make a change in every patient, and we needed to understand more the sort of personas of the patients that it did help. But overall, we found significant improvements in asthma control, quality of life, airway inflammation, and their unscheduled use of healthcare. So potential benefits to the patient, but also to the NHS as well. We also found that 35% of patients didn't need to go on to, but only 35% were then escalated on to high-cost biologic treatments. The other 65% didn't require those treatments. They just required better use of their inhalers, which they gained from using the digital intervention. So again, potential significant cost savings to the NHS. And I think one of the most important things that came out of this initial study was the patient opinion, and we presented this as a clinical case at the European Respiratory Conference, that the patient found that they'd never been told or never understood how an inhaler could fix their asthma, and they rarely used it. Now using their inhaler, they were no longer breathless or wheezy, and they could play with their grandchildren. And this was actually a 75-year-old patient, which I think we often discount from digital technology, think they wouldn't be able to use it. But this significantly changed this patient's life. And that really encouraged me to carry on with this research. We've also now reworked the literature review with my interest in sustainability benefits, and we've just published in the International Journal of Pharmacy Practice the potential sustainability benefits of this digital technology, with improving adherence could reduce reliever inhaler use and improve asthma control. And uncontrolled asthma has 8 times the carbon impact of well-controlled asthma, so potentially it could significantly reduce that carbon footprint of asthma care. But we did conclude that we do need to do these larger comparative studies demonstrating the impact on clinical outcomes and getting more health, economic and environmental data. Within my role with NICE, as I said, we did a lot of this work towards a literature review. We looked at the information for these digital inhalers, and we found that we need further data because of the heterogeneity of the current studies. We need to look at and identify which specific patient groups are most likely to benefit from these smart inhalers. And then also we need more cost effectiveness data of the digital inhalers as well. So from this, we actually published a research recommendation within the NICE asthma guidelines saying that this work needed to be done, which has really helped support me in terms of funding and moving this research forward. So now my study, which I'm undertaking at MFT, is a feasibility study. We call it the IAA, or Improving Adherence in Asthma Study. We've really worked it from identifying and prioritising this to getting the research, really looking at the research cycle. We've now designed this study. We have ethical approval and we're now recruiting. So we're doing this feasibility study, which is randomised, and we're comparing asthma control in patients who receive a digital inhaler sensor and smartphone app plus usual care versus patients who just receive usual care alone. So that's sort of 6-monthly follow-up within the asthma clinic. We were initially looking to recruit 100 patients. We may have been over aiming whether we're going to get to the full 100, but it is a feasibility study. So overall, we're looking at whether can we recruit to this study. We're recruiting patients from A&E admissions and ward admissions and those referred to the asthma clinic who would have these standard follow-ups to try and improve their asthma control. It's much earlier on in the asthma pathway than looking at high-cost biologic drugs. So it's seeing if we can make a difference earlier on before patients have a number of asthma exacerbations and are needing to be escalated to high-cost treatments. We're also including post-study semi-structured interviews of people that have been involved in the study, just to see if this sort of complex intervention can make a difference and what patients' opinions are of this sort of technology as well. Patient and public involvement has been key to our study, to planning the study and undertaking it. We did a pre-study PPI group working with Vocal, who are the PPI group within the Biomedical Research Centre at Manchester. They've been key in finding asthma patients to be involved. We discussed the study plan and patients really thought this was a good area to research and would be keen to be involved. I also have a patient contributor on the study management board, and he's been vital in terms of we found it difficult to recruit at first, but he's worked on us developing a smaller patient information leaflet, just tactics that we can do to help improve patients' opinion of the study and help recruitment as well. We're also going to do a mid-study PPI group to discuss initial results and plan for the interviews, and a post-study group to review those results and inform a future application for a randomised control trial. we hope that first of all we'll get feasibility measures to look at recruitment and retention and plan for that future larger study. But also hopefully we'll begin to get initial results on whether, compared to usual care, these digital interventions can improve asthma control, and can they improve adherence, can they improve quality of life. And we're working, we have a health economist on the study board who's helping us to look at health resource questionnaire and how we can properly look at the cost effectiveness and get more of that cost effectiveness data that we've highlighted is currently missing. Obviously, this will be part of my thesis, but I really hope that we'll be able to publish this on the clinical effectiveness of these digital inhalers compared to standard care, and also look at patient acceptability, which for this sort of intervention is essential. And then hopefully that will help inform further the national guidelines such as NICE and help to finally get that sort of NHS support and funding to implement these technologies into the clinical practice. And then hopefully we'll be able to get a research for patient benefit grant to do a larger trial and increase the evidence. And I think taking it back to that shaping research for patient benefit, I've always known in my role that adherence was a key cause of non-response to treatment and to asthma mortality. Considering this, considering the causes of non-adherence, we know these personalised interventions are needed. We know these different patient groups will respond differently, but these digital interventions could be a potential solution for some patients. And I'm hoping that this research will begin to shape and improve personalised interventions for asthma patients and try and improve those asthma outcomes within the UK. And I suppose in terms of being a pharmacist, working towards becoming a clinical academic, the opportunities are there. And although they're not always clear and although they're not always that accessible, I think, the opportunities are increasing. And people like myself, I know, are always keen to talk to anybody who's interested in research and to share our experience and to support and mentor others. And I think that it's really important to realise that the work we do shapes better practice and improves patient care. I think the first thing to do is find your area of interest, look for mentors, and use those resources such as Catalys to find the funding opportunities that are out there. And hopefully that will then lead to more clinical academics within areas such as pharmacy. So I'll stop sharing and give people a chance to ask any questions.
Thank you so much for that, Lynn. I'm just going to share our sort of bookend slide, but if anyone has questions, please put them in the chat or the Q&A. Go. And I do have a couple of questions for you while we wait to see if anyone else wants to ask you things. So that was so interesting. Thank you so much, Lynn, for sharing that. One of the things that struck me, just sort of going back to earlier in your talk, you're on the British Thoracic Society Respiratory Pharmacist Specialist Advisory Group and also on the NICE guidelines. How important have these sort of roles been to your own clinical academic career involvement?
It's been so important. Myself and 4 other pharmacists set up the Respiratory Pharmacist Advisory Group. There wasn't a pharmacist advisory group to the British Thoracic Society until a few years ago. But it's really meant that we've become recognised within the workforce plan for respiratory and recognised the sort of impact that we have. But it's also built up my network of mentors. So other people that had already become consultant pharmacists, other people that are researching within the same area as myself. It's also given me access to people within NICE, such as health economists, and people that can support my research as well. So I think it's vital to really build up that network, but also to give yourself an idea of what the national priorities are for research and where their evidence is missing. And that's really driven me to realise that my research is important and it is something I should keep doing as well.
And I think sometimes people see these titles or these roles and they think, well, that sounds amazing, but I've got no idea how I go from here to there. What suggestions would you give people? And I suppose I'm thinking pharmacists, but also other professions and maybe other researchers. How can they find these opportunities and apply?
So if you become a member of societies which within your area, so the British Thoracic Society is one of the main areas within respiratory. So I became a member because I put an abstract into their conference. But actually being a member, you then get emails about the opportunities. So there's a cost associated, but I do think it's worthwhile in paying that to get access. Also for NICE, they often put their opportunities on NHS jobs as well. So just keeping an eye out on that. Even if you're not looking for a new job yourself, you might see opportunities. And the NICE website as well, they often will advertise for these. And what I would say is, I think a lot of people think, well, that won't be for me, but just putting your name out there and trying. And you might not be successful the first time you apply, but I know I'd applied for another nice role before that I wasn't successful in, but then I was in the guideline committee. So I think just trying and ask. I'm always happy for people to ask me about my experiences in applying for these areas. So yeah, happy to be a mentor if anybody's looking for one as well.
Thanks for that. That's so interesting. I love your line. I wasn't successful, but then I was, which actually does describe, I think, my career quite often. Although maybe I wasn't successful comes up more often. But anyway, that's great. Thank you for that. We have one question in the chat from Jess Keane, which is, what do you see as the next steps for your career after your PhD?
So after my PhD, I would love to do a postdoc, if I can get the funding, and hopefully we're going to apply for, as I've said, an NIHR research for patient benefit. I think from our first application, we learned that we needed to do the feasibility study first to then reapply to do the larger study. So again, I've learned from that not being successful the first time we applied. So I would love to apply for a postdoctoral fellowship, and then to be able to carry on. I want to carry on being a clinical academic, with part of my role being clinical, part of it being research and working with university. I think so many people do it within medicine, and not many of us take that opportunity within AHPs and nurses. So that's the plan for the next steps.
Um, Another question that I had was just, I really loved your timeline where, you show the successes and then some of the rejections. And I really agree with you again about what you said about how often a rejection can lead to the next success. What's your advice for people? Because I think often people start their career on a rejection, which is really tough. What would your advice be for people who are in that situation, or maybe have had a string of rejections a bit further down? What's a good thing to do next?
I think having a good team of supervisors is vital for that part, because when you have a good team of supervisors who've done many of these grant applications, they will come back to you and say, I have had 20 of these rejections and maybe 10 acceptances, but actually having that support to not feel disheartened by it and to actually work through the feedback and find the positives in it is really important. So you will get an email back with maybe pages of reasons why you've not been successful, but slowly work through it and find the points in it that are good and the points that you can learn from, to improve your next application. That would be my main advice. And don't be disheartened, because as I've learned, it happens to everybody.
No, thanks. I think that's really good advice. And the last question I have is just about the focus of your work. So I'm a clinical psychologist by background. I'm familiar with quite a few psychologists who do adherence work. So it really sort of strikes me that your work is sort of inherently interdisciplinary, in that you're combining sort of psychological approaches and ideas and problems with pharmacy. How have you found sort of bridging that disciplinary, I don't want to say gap, or,
Yeah, so I actually have a psychologist who's supporting the study as well, which I should have mentioned. So Kira, who has worked on similar studies to this in other areas such as diabetes. So she's supporting it in terms of how we can look at behaviour change as well. So we have a questionnaire within the study that looks at adherence, and we're looking at behaviour changes from that. And I think having her advice has been vital, because like you say, it's not been my area of expertise. So we made sure within the grant that we had funding for her support. And I think that's really important, is to think about all the support that you need within it, because you can't be an expert in every area. So yeah, and there's so many resources within the university as well. I actually went to the NIHR. They have like a support team that you can go to, and they can link you in with different people that would be good to work on your grant as well. I will try and find the link for that. I can't remember the exact link, but I went to them and asked their advice, and they put me in touch with Kira.
And has there been any challenges or issues that you've had in doing that sort of like transdisciplinary work is probably the best word for it? Um,
Not so much, but I think within my clinical role, I work within a large multidisciplinary team that involves psychologists, physiotherapists. So I think day to day, I work within a multidisciplinary team. So I think I'm quite used to that. But I think it's just vital to understand that you can't know everything, and that you're going to need support in other areas as well.
yeah, that's fantastic. I think working kind of across disciplines is such a good way of moving knowledge forwards, but hard as well. Great. Well, thank you so much, Lynn. That was absolutely wonderful. We've got a couple of people that are saying they want to reach out, so we'll sort of connect you after this. And I guess just to let you all know, thank you so much for joining, everyone. It's been such a pleasure to have you. The recording